I've worked with Willem for, I don't know now, since 2018-ish, I think we first met. And Willem had the absolute pleasure of being, I'm sure, of being my PhD supervisor, and has been a great friend and colleague. And I'm very happy to welcome him to this, the first of our meetings. Thank you very much, Willem.
Thanks a lot. Thanks, everyone. I'm pretty sure you can see my screen. That should all be sorted.
We can see.
Perfect, great. I'm going to then go straight ahead, and I'll switch off my camera just so that you can only focus on the content and not on my face. Thank you, everyone, for joining. I'm going to be chatting to you about emergency care systems and how it relates to road traffic injury. But when we talk about emergency care systems, it is important for us to understand that when we look at and strengthen emergency care systems, we of course don't only strengthen it for one particular condition or presentation, because when an emergency care system is established and strengthened, we are actually saving lives for all kinds of presentations of life-threatening conditions. So I will bring it back to road traffic injury as often as I can, but a lot of this also, of course, focuses on emergency care systems in general. So as Tim mentioned, annually we see about 1.3 million deaths worldwide because of road traffic injury. And low to middle income countries, of course, account for 90% of all of the global fatalities, showing us that, you know, there is a massive concentration and burden of this in the poorest nations on the planet. Forgetting about only the human toll that road traffic injury actually results in, we also see that estimates suggest that road traffic injury accounts for or costs about 2.6 of the gross domestic product in low to middle income countries. So it also then ends up having this massive economic cost, which means that these economies are strained by this, and it potentially keeps these economies from developing. It has been suggested that in some low middle income countries, reducing the impact of road traffic injury may lead to reducing costs in 7 to 22% and increasing GDP by that amount if we were to reduce the impact. And one of the key ways to reduce the impact then is really through... Great, thanks, Tim. Is really through strengthening emergency care systems. And it's important for us to just differentiate between system strengthening and system support if we're going to be talking about strengthening systems. So system strengthening really is about permanently making the system function better, not just filling gaps or supporting systems to produce better short-term outcomes. It's really about understanding that we place lasting interventions in place, like regulatory reform, sustainable financing mechanisms, and so on. But before we get to emergency care systems, it's important for us to just quickly understand what a health system is, because an emergency care system will fall into a health system in that way. So health systems then are all the activities whose primary purpose it is to promote, restore, and maintain health. And this tells us that the health system is beyond only the emergency care system and beyond the healthcare system, which focuses on really treating health conditions. And this demonstrates that all of the things, including the social determinants of health, and education as an example, upliftment and poverty, all of these parts are important for us to improve health and to ensure that people can live happy and fulfilling lives. Now, of course, if we're thinking about road traffic injury and responding to it as a health system function, we have to acknowledge that it then is a multidisciplinary, multi-departmental approach to improving health, to improving outcomes from road traffic injury. And this is then the safe system approach, which of course has a very strong emphasis on prevention and avoiding the accident, of course, happening in the first place, or the crash happening in the first place. But we know no matter how much prevention we end up putting in, unfortunately, road traffic injury is almost inevitable. And until we can really make sure that prevention is consistently applied on the entire world, we will need to respond to and manage victims after a road traffic injury. So the focus then for us here, and of course for Impact, is on ensuring that once a crash has occurred, that we are able to respond effectively and that we can save lives and reduce disability or impairments following that road traffic injury. This is something you know pretty well, I'm sure. And this is the road injury chain of survival, which was devised a year or two ago. And it really emphasizes those different elements that are needed to optimize outcome. And it sort of creates a unified goal of where we want to go when we are, when we are trying to improve our response to road traffic injury. But of course, underpinning this chain is an entire system that needs to be developed and that needs to be supported in order to ensure that we can run through the road injury chain of survival. And if you do emergency care systems work, when you wake up in the morning, this is the framework that you see. And when you close your eyes at night to sleep, this is the last thing you see as you drift into sleep. And this is the emergency care system framework, which was devised by the World Health Organization. And what it does is it gives us a visual representation of how we should be organizing our emergency care system to maximize outcome. And what it does is it takes us through from the incident and talks to all of the different important functions that we need to put in place, all the way from the incident and the scene care through to the facility care and to final disposition of that particular victim. It also includes all of the different human resources that we need to put in place, all of the different key functions, as well as some of the policies, technologies, and equipment that we need to support the system and to ensure that there is maximal efficiency within the emergency care system. And this is what the basis of the rest of the conversation is going to be on, is to really talk through some of these particular components, maybe chat through a little bit of the evidence around each of them, and then we'll wrap it up in terms of system strengthening. But of course, I live and work on the African continent, which of course is an incredibly diverse place. Hopefully you know that it's not one country. There's more than 50 countries on the continent, with incredible diversity and different challenges as it relates to emergency care system strengthening in each of these countries. And while this survey is being updated now, in 2017, only about 30% of countries on the continent had any kind of emergency medical service available. And this served only about 8.7% of the African population, meaning that back then, and of course there's been some improvement, and we're looking forward to getting the results of the survey now almost just under 10 years later, but that meant that that in 2017, 90%, more than 90% of the African population did not have access to any out-of-hospital emergency care services. And some of the important barriers that were found to prevent access to emergency care, whether that was in places where they were where the emergency medical services systems were established, or in places where they weren't, these barriers related to both culture and community, including the ability to recognize that an emergent health condition has actually occurred, and you'll see how that, of course, translates to the road injury chain of survival, and talking about infrastructure, how to get to the injured, and of course, roads and road infrastructure not only prevents or complicates getting to road traffic injury sites, but also, of course, contributes to road traffic injury. So it's kind of like a double-edged problem. Communication and coordination of emergency medical services, of course, is an issue, including telephone triage of callers, and how to elevate certain emergencies over others in a coordinated and accurate manner. Equipment was also a problem, as well as human resources and adequate training for emergency care responders. So, given the backdrop of all of these barriers and the fact that formal emergency medical services do not exist or did not exist back then on the continent, we'll see what it looks like now. The African Federation for Emergency Medicine devised and this has consequently been adopted by other system strengthening organizations, adopted a two-tier out-of-hospital emergency care services system. And this two-tier system relates to first responder care that is seated within the community and is comprised of trained community members who are then able to respond to an emergency situation. And that's called a Tier 1 system. And then the Tier 2 out-of-hospital emergency care system then comprises of more formalized emergency medical services and pre-hospital care and transport, which then would be accompanied by all of the different components of what you would expect a out-of-hospital emergency care system to look like, including credentialing of pre-hospital providers, organization in terms of dispatch and universal access number, and so on. So when we think about strengthening out-of-hospital emergency care systems, we do start with often as an initial win the focusing on a community-based intervention, and then continue in strengthening that system through formalizing the emergency care system and pre-hospital care. And this, of course, can take a while to do. And then, of course, we have also instances where you might have a conflict situation where there is a formal out-of-hospital emergency care system. However, because of circumstances, you would establish a Tier 1 system within a particular community or geographic area, and you would then and they would then be responsible for immediate care, and then they link into the Tier 2 system later on. And this was sort of devised actually in Cape Town, where I live now, where we have certain communities where there's quite a lot of violence and safety concerns. And in these areas, the idea was then to establish these community-based services so that people who are injured may be immediately, like hemorrhage control and those kinds of interventions can be immediately applied, while a ambulance is actually then escorted into the area under escort by law enforcement or police services. so that we can actually try and improve outcome. So back to the emergency care system, I'm going to be running through each of these different parts, from scene care, which is comprised of bystander response, dispatch, and provider response, transport, but I'm not going to talk about facility care, just because, firstly, out-of-hospital emergency care is 2 out of 3 parts of the emergency care system, which probably, and I am biased, but probably tells you how much more important it is. And also because this is my field of study, is in the out-of-hospital emergency care space, and I find it a lot more interesting. So I'm going to avoid facility-based care for the moment, but you can see that that involves early resuscitation following handover. It will then require a triage and screening for life-threatening conditions, and then assessment, resuscitation, and early interventions, including early critical and operative care to avoid death and improve functional outcome. So first, let's chat about bystander response. And bystander response really, chiefly if we think about the main interventions there for strengthening the emergency care system, we think about a universal access number, we think about training, and we think about bystander protection laws. Now, the universal access number is where you have a toll-free number that anyone in a country can call, and they will then reach an emergency care service that they can hopefully then get emergency care from. Now, actually, most places on Earth do not have a single universal access number. And of course, especially where formal emergency medical services or an out-of-hospital emergency care system is not available. But what's important is that these UANs do promote access. It minimizes confusion and therefore decreases delays in actually accessing the care. But what's really important also is it doesn't help you have a universal access number and people phone it, and then it takes you hours and hours and hours to actually receive care. That will undermine public trust in the service, and then people will actually stop phoning it. And there are a couple of examples on the continent, or on the African continent, that I know of, where this has resulted in really low uptake of the universal access number after injury or after illness. The next is on first aid training, and training either the community or those that are in a professional proximity to road traffic injury. For example, taxi drivers, law enforcement, or those on a corner shop, as an example. Training those have shown to, of course, increase knowledge, skills, and confidence in applying first aid following road traffic injury, but also increases then the willingness of these people to actually act and apply their skills following road traffic injury. It's been shown that it may increase survival by up to 13% in some low middle income countries, and it may increase functional survival by up to 28%. So not only survival, but actually surviving without impairment. But multiple barriers do exist to accessing these trainings. And here are a couple of individual and system level factors that we found to be barriers globally to accessing life-saving skills training. And what I found really interesting from the survey that we ran is one of them, or some of the most important barriers really relate to the perceptions of how important this might be, and the cultural and social pressures, how those orientate the way that we perceive the need for having these skills in communities. Affordability, of course, was also a big problem, and being able to legislate against a requirement for first aid training was also seen as quite important facilitators to to accessing or making life-saving skills training more accessible. So it shows us that, it's not only about encouraging people to undertake training, but also about putting the structures and the regulations in place to be able to actually to regulate this and to make sure that that the community can actually access these kinds of trainings. And then fear of legal and other consequences is probably one of the major barriers to caregiving behavior following a road traffic injury. And these fear of legal consequences not only relate to civil claims against a bystander who has provided care, but in some countries, police tend to prosecute bystanders who engage in care, and maybe the outcome is bad. They could potentially be held criminally liable, not only civilly. And then in other places, those who engage in bystander care, they can also be liable to healthcare costs of that particular victim. And also there could be other obligations on them, like needing to transport the person to hospital, and then of course needing to pay the bills when the person's admitted to hospital. So a good bystander protection law then does have to protect the individual against legal repercussions, cost, any obligations to transport, and police harassment following these laws. And India is one of the countries that has some of the best bystander protection laws in all LMICs, but unfortunately, during the implementation of their bystander protection laws, they were not the dissemination of that law and the education that had to go with it wasn't actually done very well. And that did result in a lot of the public not actually knowing about the new bystander protection law, and therefore there wasn't actually a transition into more bystander action following a road traffic injury or any other emergency. So it just tells us again that we can't, just having these laws in place is often not sufficient to strengthen the emergency care system properly and sustainably to improve outcomes. One thing just to say is we had over the last 2 days in Cape Town, we had some engagements with multiple stakeholders, including community stakeholders around how we can orient emergency medical services in our province. And we used the emergency care systems framework as a foundation really for the discussions. And the community members basically said that they do not like the term bystander because it assumes passivity, and they instead preferred the term first responders or first responder networks. So I think that's also something that we can look at or should look at to ensure that, even the words that we use do actually promote a sense of ownership and comfort within the communities that we aim to apply emergency care system strengthening to. Then moving over to dispatch, again, 3 things that we can consider there is telephone triage, how do we organize the emergency medical dispatch system, and the provision of pre-arrival instructions. Now, as it relates to telephone triage, globally, the telephone triage systems that are in place, maybe just to say telephone triage is the process by which a call taker or a dispatcher would, based on what is given over the telephone, would decide the priority of a particular response or ambulance response, and then also which sort of vehicle to send, especially in emergency care systems where there are multiple cadres to deploy, and each of these, of course, would have a differing scope of practice. So you would need to decide what type of vehicle you also send. Now, globally, you can see that the over-triage rates are about 71 to 78%. And over-triage, of course, is when you ascribe a higher priority to a condition than or an emergency than what is actually warranted. And this results in resource waste. It increases cost. And it also often, of course, would then result in a lights and sirens response, which places the safety of the responding crew as well as the community or other road users, their safety in jeopardy. And the under triage rates globally seem to be between 3 and 4.5%. And over triage, under triage, sorry, of course, is when a case is ascribed a lower priority than what it actually is. And this then, of course, results in a patient safety issue where you would not prioritize a patient who needs to be prioritized, and they might have delayed care. Now, you might think that these numbers are pretty okay, but in systems with limited resources, such high over triage rates just are not sustainable, because it would mean that, everyone would get a high priority response. And unfortunately, there just aren't enough emergency vehicles and resources available for that. So in South Africa, and specifically for road traffic injury, we have a over triage rate of 68% and an under triage rate of 16%. So you can see that our over triage is still actually quite high for road traffic injury, and we really need to bring that down through our triage processes. And our under triage rate is also quite high. I mean, 1 in 5 cases are under triaged for road traffic injury, which is quite a big problem, and needs to be addressed, because this, of course, presents as a patient safety issue. So then we've developed a process of making telephone triage models in South Africa, which we are in the process of testing for accuracy. But what we basically look at is we understand first the context, because, for instance, in a system where you can support, where you could potentially support cardiac arrest from road traffic or following road traffic injury or other traumatic cardiac arrest, if your system can support that, of course you can prioritize injury, someone with an injury who does not have a pulse or who is not breathing. But in other contexts where you do not have the luxury of being able to prioritize patients who are clinically dead, that will not be a priority and shouldn't be a priority in that system to respond to those patients over others. So it's important to understand the context and what downstream resources, as you look at the road traffic, the road injury chain of survival, what those downstream resources are available and how quickly you can get to theatre, etc., whether you have blood available and so on. All of those kinds of things should really form the context and how you then end up prioritizing these cases. Next, we think about qualitative descriptors. What are people saying over the phone? Because the call taker really can only use the descriptors that the caller is giving to determine, what the appropriate response would be. Then we look at some clinical variables that you could potentially gather over the phone. For example, is there uncontrolled hemorrhage? Is the person unconscious? Maybe some things around mechanism of injury. And then we use those clinical variables to compare them against a few dependent variables, like, for instance, mortality or actual on-scene triage level, or what the final diagnosis of that patient was. And you then compare those clinical variables and the qualitative descriptors to build an algorithm to see how accurately the combination of different questions that you're asking the accuracy of which it can then predict that kind of a dependent variable, for example, short-term mortality. Then we test that for accuracy to see how good it can do it. And then we just try and look at what cases were missed, what cases were over triaged and under triaged, and what were the causes of that. Should we maybe not look at unconsciousness, or maybe it was breathing or something like that, that we can then include or exclude from the algorithm, and then we retest the accuracy. And then, of course, once the algorithm is built and it's quite accurate, the triage algorithm now, you have to implement it through training and coaching and quality assurance within your dispatch system to make sure that the call takers are aware of it and they know how to ask these questions in a way that's appropriate to the population that they're talking to, including what their preferred language is, and based on their health literacy and some of the colloquialisms that would be used within that particular culture and their language. Then when we look at emergency medical dispatch training and organization, there's almost no guidance available for systems that are just starting up. The telephone triage, as an example, systems that exist like MDPS in the United States are just completely unaffordable for systems starting up. Like, I think if I remember correctly, it's something like $10 million. A low middle income country context cannot afford that kind of an investment in a triage system. So other kinds of approaches need to be considered. And then the question is, how do we end up organizing our dispatch systems? So first we get a combined and separated dispatch. So combined dispatch is where, for instance, fire and emergency medical services are in a single dispatch center. And this, of course, is relevant in terms of road traffic injury, because road traffic injury will require a multi-agency response, because the scene needs to be secured, there might need to be some investigation occurring, and there's of course an emergency response. And while this doesn't happen often, but fire might also need to engage in extrication, and we know from the exit project that that's often not a good idea, and patients who can self-extricate should. But the advantages then of this combined dispatch system is then streamlined communication, resource optimization, and a multi-agency collaboration. But there is complexity in training, and there might be some volume overload in that one system, especially if there is some kind of a surge, like a multi-casualty situation. Separated dispatch systems allow for sort of specialized and ring-fenced expertise, and they can focus on their service-specific protocols. And there's clear accountability of who needs to be involved, and who needs to take responsibility. But the issues are that there's, of course, resource duplication, because everyone would need a call taker at a dispatcher. There could be issues with coordination, situational awareness. You have no oversight of what the pressures are in one of the other emergency services, and this can cause public confusion of who they actually need to call, which can delay a response. Then we have centralized and decentralized dispatch. So centralized dispatch is where one dispatch center manages and coordinates all emergency responses. And decentralized is where there's multiple dispatch centers across different regions, and you're only responsible for your own region. So again, centralized can allow for resource optimization. You can have cost savings, quality control, and lack of variation in quality, and consistency that may occur. But again, there's a risk of overload. There's a loss of local knowledge, because if you're especially in large countries, which is often the case, like on the continent as an example, you might not know the geography and the local resources available in every single region in an entire nation. But decentralized systems, of course, while they have the local knowledge, and they can bring in some cultural sensitivity around those particular regions, there is resource inefficiency and a risk of lack of standardization, and there might be some redundancy because you won't be able to easily just transfer to other the systems. Lastly, we look at pre-arrival instructions, and this is in the absence of large-scale first aid training, these allow for scalable, cost-effective interventions that can be applied as participants or as callers actually require them. When we look at provider response, we see that systematic reviews have found that in road traffic injury, as an example, it's often the basic life support training that has the largest initial effect, and there's limited evidence of benefit of advanced life support interventions, which shows us that when we start strengthening a system for road traffic injury, we don't have to immediately think about ALS interventions, but often it's the BLS stuff that actually improves. We know that provider responses are multi-agency, and this allows for expedited care, but often, if not applied appropriately, like has been seen in the EXIT project, it can actually delay care and therefore decrease good outcome. And then governance is really important, because oftentimes when an emergency medical service is established, there isn't quite an oversight body, and this allows for variations in quality, and oftentimes there's lack of accountability. And in many places, emergency medical services are not seen as a health function, but rather as a public safety function, or as a fire function. And in these instances, what we see is that out-of-hospital emergency care is not actually included in the essential health service package of a particular system. And this means that it's very hard to work with those regulatory frameworks to try and ensure that outcome is improved. When we look at transport and transport care, then we find that in some places it is encouraged that if there isn't an ambulance or an ambulance service available, that these patients be moved to hospital using some kind of other non-ambulance transport, like police transport. But we find that there's mixed outcome in data. For example, if I think it's a Ugandan study that found that if road accident or road crash victims are transported by police, they have worse outcome. But if police are trained, then they're able to ensure ongoing care during the transport phase, and this can actually improve outcome. We talk about destination triage a lot. Where are these patients going to go? And while in high-income countries, there's a requirement or a suggestion that they go to major trauma centers, unfortunately, major trauma centers don't exist in many LMICs. And where they do exist, they are quite far away and centralized in large countries. So this means that these kinds of destination triage protocols might not be relevant or safe in some contexts. And it's therefore important for all facilities to be able to manage major trauma, at least for the acute resuscitation phases. And then when we talk about field to facility communication, we talk about pre-arrival notification, and we know that there is there's unclear requirements of what the facility should do in many places when they are pre-notified, and there are variability in practice depending on who's on duty or which place they're going to. So part of strengthening then the road traffic injury response is also to ensure that these kinds of what should happen when there is a pre-notification, that they are also dealt with and protocolized. So now that we've gone through just some of the important functions and strengthening requirements of emergency care system strengthening, it's really important that we just quickly talk about strengthening versus support. And you will remember earlier I said strengthening results in lasting improvements, while support might not. This that you see on the screen here is the health system cube, health system strengthening cube that was published by T et al. In I think 2017 or so. 2013. And this cube argues that oftentimes when you think about strengthening a system, there is some confusion between system support and system strengthening initiatives. So support activities, like for instance, procuring ambulances and medications, training staff, and providing equipment, and these are often among programs, like you can see here, they speak about TB programs and HIV programs, but road traffic injury programs would also fall within that. They often only have really short-term gains, and they're not really sustainable after the funding ends up leaving. So when we talk about aid and grant projects and those kinds of things, oftentimes when the funding runs out or the grant cycle ends, the system strengthening or the system just relegates to what it was before. But in contrast, strengthening activities address underlying performance drivers like policy, governance, regulatory frameworks, integrated care, financing mechanisms, workforce, etc. And if you are focused on strengthening these parts, and you can see on the cube, it's these performance drivers that we use to improve system strengthening. They often last beyond the funding cycle, and it's therefore important that when you think about improving the emergency care system, that you also think about building capacities that allow for the system to self-correct and adapt to different situations, and also respond and continue improving. So sometimes, yes, it is important to start with an initial system support process like training, but it's also important that when you think about training bystanders or pre-hospital providers, you also think about how you should work on the regulatory frameworks, leadership capacity building, etc., to ensure that these interventions are sustainable and can move forward. We also can't talk about system strengthening without talking about equity. Now, equity is really about recognizing that we do not all start, both in terms of individuals, in communities, in terms of countries, we don't all start from the same place because of structural, societal, or historical factors. And oftentimes when we have to think about system strengthening in the African context, we have to talk about, for instance, in South Africa, the impact of apartheid and racial segregation. We need to talk about, in the context of the continent, also about colonial pasts. We have to talk about some of the problems, well, not problems, some of the inequities that relate to refugees and refugee status, and immigrant communities, and so on. So we really need to think about the structural, societal, and historical factors that make us start from different positions. And once we do that, it also demands of us to then acknowledge and make adjustments for these imbalances as we are strengthening our systems. And it's important to understand that equity is not the same as egalitarianism. It is not the same as everyone gets the same. It requires us to identify and overcome intentional and unintentional barriers in society and provide protections and additional resources to those that need it, and so that they can participate meaningfully and have a meaningful and healthy life. And it's important that equity is also not a thing. It's not a moment, much like universal health coverage. It's not a moment. It is a process that is ongoing and becomes a progressive realization. And it should evolve as we overcome some barriers and we develop our own societal consciousness around where some inequities end up living, and what the consequences of them are. And this is really a nice little picture that I like to always think about when I think about all of these different terms. And equality is then unequal access to opportunities, right? Sorry, inequality. Equality is then where what we have is evenly distributed, so everyone gets the same. But as you can see here, how this tree is bent due to societal and historic structures, even when these two characters have the same size ladder, they don't all get the same opportunities. Equity then is to ensure that custom tools are provided so that these inequalities are actually addressed. Okay, so it doesn't mean everyone gets the same. It means that everyone gets as much as they need so that they have the same access to resources. And justice then means that we are fixing the systems, the underlying systems that prevent this in the first place. And only then can we move um, to everyone getting the same resources and help. And unfortunately, as you see, the world is just in shambles, and we are really battling to see justice really occurring because of multiple different powers that are functioning. But it's important that if we're thinking about improving care and improving emergency care systems, we cannot forget about justice, because we do not want to build systems that continue perpetuating inequity. And why is equity then important? Well, literature shows us that women are, as an example, women are consistently less likely to receive high priority responses for injury. They have less direct trauma transport, and they often have inadequate analgesia following their injury, despite having more severe injuries. Another thing is that people with disabilities and some racial minorities they experience poorer pain management and also higher fatality risks. Um, and they experience access barriers, especially, for instance, non-accessible emergency call systems for people with disabilities, as an example. These still persist. Rural populations face a 3 to 4-fold longer EMS response time, and their severe workforce shortages is a difficult word for me to say, it seems, this time of a Friday. Compounding poorer outcomes, and this compounds poorer outcomes after road traffic injury. Poverty restricts access to care, with some users, example on the continent, needing to pay out of pocket for ambulance fuel before the ambulance can actually transport them to hospital. And this often leads to catastrophic health expenditure. For instance, one study in Tanzania found that 80% of patients had a catastrophic health expenditure following injury. And in Ethiopia, 67% of patients following injury had a catastrophic health expenditure. And in a quarter of these families, or a quarter of all families, that catastrophic health expenditure pushed that family under the poverty line. This is after injury. So these inequities highlight actually that there is an urgent need for us to develop our emergency care systems using inclusive lenses, and ensure that equitable resources are distributed across geographies, genders, disabilities, and racial lines. And also that we need to, when we are collecting data, we need to have disaggregated data, because actually we cannot actually measure the inequity if we don't have disaggregated data in terms of all of the different types of vulnerabilities and inequities that exist. And these will be different in different places. In some places, it needs to be along the lines of language. In others, it needs to be along the lines of ethnicity and heritage. In others, it needs to be, well, in all, I would argue, it needs to be along the lines of gender, along the lines of household income, etc. And this would need to change based on what some of the inequities are. And by ending on equity, I think that's what I want to leave you with. So we spoke about what are emergency care systems, what are some of its components. We looked at what are some of the interventions and things that we can think about to strengthening these systems for road traffic injury. We spoke about the difference between strengthening and support, and when we need to think about which. And then we looked at very importantly, equity, and understanding that we each have our own positionality and our own privileges that we need to look at. But it's our responsibility as people who are working in emergency care systems to ensure that as we develop them, we do not perpetuate inequities, but we develop our systems to improve justice, and to ensure that we actually end up saving more lives and minimizing poor outcome and impairment. Thanks, everyone. Thank you, Tim. Over to you.
Thank you, Willem.